Good evening. My name is Leanne Martin, and I'm the Dean of the College of Humanities and Social Sciences at Western Washington University. So I, along with Associate Dean Mark Geisler and Kirsten, who's outside, and Kim Ayer, who's somewhere here, would like to welcome you to the second installment of the Dean's Lecture Series for this academic year. So this presentation is brought to you by a really good partnership between our college, CHSS, and the city of Bellingham, who's letting us use this wonderful venue, and also Bellingham TV, who is recording this presentation, and they'll also air it multiple times in the coming weeks. So as a matter of housekeeping, at the end of the presentation, there will be time for questions. Mark Geisler will be moving around in the audience, and he'll provide the microphone to anybody that he sees with hands raised. Please do wait for the microphone to come before you talk, because this is being recorded. So I would like to thank our Bellingham partners and CHSS staff for putting this on. Part of the mission of our college states that students will learn to devise and apply innovative solutions and participate in scientific exploration to contribute to the well-being of communities, both local to global. Tonight, Dr. Jun San Juan will do this as he discusses Born to Run, Biomechanical Factors of Running Injuries. Dr. San Juan is an assistant professor in the kinesiology program in the Department of Physical Education, Health, and Recreation at Western Washington University. He teaches undergraduate and graduate courses. He is also a certified trainer through the National Athletic Trainers Association. Dr. San Juan received his Bachelor of Sports Science degree from the University of the Philippines. He completed his master's degree at San Diego State University and his PhD at University of Oregon. Sorry about the ducks. Both his master's degree and his PhD are in the area of biomechanics. Currently, he leads the Applied Biomechanics Lab at Western Washington University. Dr. San Juan's research interest is in the injury prevention and rehabilitation area. He focuses on injury biomechanics of the shoulder, hip, and knee. He's authored or co-authored many articles that have appeared in international peer-reviewed journals. His goal is to bridge the gap between researcher, clinician, and the general public. So it's my great pleasure to introduce to you Dr. Jun San Juan.
Thank you, Dean Martin, for the warm introduction. Thank you all for coming today. Kind of the goal of my presentation is to talk about what are the biomechanical factors, or what are the mechanical factors affecting or predisposing an individual to running-related injuries. So my interest started with this topic before I moved here to Bellingham, Washington, when I was in, I don't know if Eugene, Oregon has kind of put some interest into that, but I was working in a clinic, and through my experience as a clinician, we saw a bunch of, or numerous athletes, and not just athletes, but also recreational runners that has a lot of this running-related injuries. And it spans from, you see from high school all the way to elderly individuals. So that really pushed me into going into this line of research. So I want to start with looking at what are the trends in terms of long-distance running, especially I want to focus on cross-country running. So according to the National Federation of State High School Association, within 10 years, there's about 30% increase in participation in cross-country. So that's quite a bit. In 2006, Raw et al. From Seattle, Washington, did a study. They did looking at how many participants. They look at about 450 high school cross-country runners, and they've seen that there's about 39% of them gets injured throughout the entire season. So that's pretty much a big rate in terms of injury for those cross-country athletes. If we look at long-distance running in general, they've seen to about a rate of 79% of runners could experience lower extremity injury. And if you're training for a marathon, that rate goes up to 90%. So it's really a concern. So in order for us to understand this, we need to know what are really the major causes of running-related injuries. So according to studies, there are two main reasons, or the reasons for this running-related injuries. So the first one is training volume, and then the other one is mechanics. When we talk about training volume, the studies have shown that if an individual is averaging more than 40 miles per week in terms of running, they're increasing their chance of getting injured. So kind of they set that threshold to 40 miles. And we know ultra runners, marathon runners, they probably average 50 to 60 miles per week. So they kind of see that that's the trend. If you increase by 40 miles per week, you got a big chance, or your chance of getting injured increases. So for this talk, I want to focus more on the mechanics. Okay, so I want to focus on what are the different mechanics looking at the body. What are the different mechanics that could lead or predispose that individual to running-related injuries? So when we look at running or running gait, there are different phases. So there's a swing phase and a stance phase. So swing phase is when a person, so this is unique with running because you're kind of floating. So your feet is not touching the ground. And then on the stance phase, now you have contact with the ground. So that's where we're going to focus. That's where the injury occurs, at that stance phase. When we look at the stance phase, there's three main divisions or categories. The first one is the initial contact, or where your foot hits the ground. The next one is the loading response. So that's when you're accepting that load coming from the ground. And then the last part is the terminal stance. So I kind of will go onto each of those different phases of running. So first, initial contact. So in 2007, Hasegawa et al. From Japan did a really good study. They were the first study to look at a bunch of marathon runners in real time, and then they put a video camera on the 10-kilometer mark, and they try to look at the different initial contact patterns. If you're not familiar with initial contact patterns, there are three different initial contact patterns. The first one is the rear foot strike, which, as you can see in here, about 75%. I think there was about 500 runners that were able to look at this. And 75% of them, when they hit the ground, they hit on the rear foot or on the heel. That's very common. The next one is a midfoot striker. This is when you're hitting the ground flat foot. Okay, so that's about 24%. And then the last one, which is the forefoot strike, there's really only 1.4%. So in 2009 and 2010, so who are runners in here? Either recreational or competitive. So we got quite a bit. So you guys kind of have an idea in terms of a different foot strike. And then the history, or kind of going back into in 2009 and 2010, that's why my title was Born to Run. There was this book that was released that was talking about, I think we should be changing how we are running. And so in 2009, the book was released. And in 2010, a minimalist shoe came, right? So we have all those really thin-soled shoe. And so the goal of that is for everyone to run forefoot strike. So in 2011, they did another study, but it was done here in the United States, in New Hampshire, in a marathon. And they they kind of mimic what Hasegawa did in 2007. So they put a video camera on the 15-kilometer mark, and then they were able to get about 900 participants. So if the trend continues, like I think it was more of a fad, that this should change, right? Because of what's forefoot striking and all of that, which is really surprising because if you see here, there's not much of a change between the rear foot strike and forefoot strike. The rear foot striker even increased. So really, you could see that majority of the marathon runners weren't changing their initial contact patterns. Okay, so now we're going to have a little bit of a quiz, kind of to wake you up. It's 7 o'clock. No pressure though. If you get it wrong, that's fine. So here's the question. How much weight does your lower extremity absorb at initial contact during running? So is it A, B, C, or D? So think of it as how much, if it's half times your body weight, 1.5 times your body weight, is it 2 to 3 times your body weight? You could talk to your neighbor if you are not sure about your answer. Once you figure out your answer, if you have a flyer, on the back of it, there's a QR code. So what you're going to do is you have to have the letter on top, and you raise it up, and I'm going to scan it, and we could see the answers in real time, okay? So, disclaimer, I'm not taking a video or a picture of you, so you don't have to be afraid. If you're afraid, you could put that in front of your face. Okay, you guys ready? Okay, so here we go. I don't know if I can go all the way back, but I'll try. See, this is a good way to check attendance, right? Okay, thank you. So, according to here, 14 of you said that the answer is C. Let's look at the correct answer. So the correct answer is C. So there's a big difference in terms of how much your lower extremity has to absorb when you're walking and when you're running. When you're walking, it's about 1.5 times your body weight. When you start running, it goes up to 2 to 3 times your body weight. Think of it. So 2 to 3 times your body weight, just to make the math simple. If a person is weighing 100 pounds, so their lower extremity has to absorb 200 to 300 pounds. And if you're training for a marathon, if you're running over 40 miles per week, that's a lot of steps and a lot of load that your lower extremity has to absorb. Okay, so that's kind of the difference between those, the walking and running. You guys did a good job. Okay, so first, in terms of the difference, in here we're looking at what we call a ground reaction force. So probably some of you are not familiar with ground reaction force. If you think of ground reaction force, just really the amount of force that the ground is pushing on you. So it's kind of like Newton's law, right? So we're going to be looking at 2 different strike patterns. On the left side of the screen is rear foot, and then on the right side of the screen is forefoot striking. And then we'll look at the bottom, this is the ground reaction force vector. Usually in the lab, how we measure it is we have a force plate, and we ask individuals to run on the force plate. They step on the force plate, then the force plate gives us this curve of the ground reaction force. So let's look at, and I want you guys to observe what's the main difference between the ground reaction force between the rear foot and the forefoot. So here's the rear foot contact. Okay, and here's the forefoot contact. So as you can see here, if we pause at the top of the peak, right in here, that's kind of close to it. You can see that the body weight is 2.4 and 2.39. So there's really not much of a difference between a rear foot contact and a forefoot contact between ground reaction forces. And that's kind of what some of the claims they're saying that forefoot contact is better because you decrease the load. But according to this study done by Lieberman in 2010, there's really not much of a difference. The main difference is if you look at the curve, on a rear foot strike, there's this transient heel strike. That's when you hit the ground. So now you have 2 active peaks. So you have one right in here, and that's the second one. If on a forefoot contact, you don't have that active peak. So you only have 1 instead of 2 active peaks. So that's really the main difference. Another concept that I'll be explaining later on is the rate of force development or loading rate, which there's a difference between rear foot and forefoot contact. So rate of loading or rate of force development is, think of it this way. if I am going to break, or if I have a twig, I could apply two types of or forces to break it, right? Either I break it slowly, or I could break it fast. So the faster I load that, then the more chance that I'm going to break that twig faster, right? So that's what's really the difference between a forefoot and a rear foot strike. As you can see here, the rate of loading is the slope of the line. Probably you guys remember what the slope of the line, right? So as you can see here, here is a curve of a rear foot strike, and here is the curve of a forefoot strike. If you look at so slope is just the rise over run. If you look at the slope of the rear foot contact, it's higher compared to the slope of the forefoot contact. So the steeper the slope, the higher the loading rate, the more injury. If the slope is not steep, or if it's not steep like the forefoot contact right here, now you're applying that load in a longer period of time, so now your body has time to adjust to it. So think of it easy that way. So what they did in this study is they look at different conditions in terms of initial contact. They look at a rear foot strike, but they were running barefoot. They look at the rear foot strike now with shoes. And then the last one is a forefoot strike with barefoot. On the vertical axis is the rate of loading. So as you can see here, when you are running barefoot and you are hitting the ground on your heel or rear foot, that rate of loading is way up there. So it's close to like a mean of about 500 in terms of the rate of loading. So when we put shoes on a person, though, and you ask them to run the same thing, rear foot, you could see that there's a significant decrease in the rate of loading. So really, you could just wear shoes, and it's going to be the same rate of loading as a forefoot strike going barefoot. Okay, so that shoes really helps, and that's why you have those different types of shoes in order to help you dissipate those forces to increase the rate of loading. So don't be shy. Raise your hand if you have this type of shoe. So we have a couple. You're in luck because they just lost a lawsuit in May. A female just sued them for all of these claims that it's not true. So they lost the lawsuit, and you might get money back from it if you bought your shoes from 2009 to 2014. So this is what a minimalist shoe is. So usually you wear a minimalist shoe if you're a forefoot striker, but if you're a rear foot striker, you really don't want to wear a minimalist shoe or those really thin-soled shoe, because you can't decrease the rate of loading. Okay, compared to if you're forefoot, then you could use that. On the other end of that spectrum, or that continuum, nowadays with Ultra Runner, this is what they are using now. See the big difference in here? So these are called Hokas, and they are really popular right now with ultra runners. So you could see that that sole is really, really thick. So those are the ones that are using right now. So last summer we were asked by one of our colleagues to look at an injury. The person was having some lower extremity pain from running, and so we asked him to come over to our lab. We did some gait evaluation. And so I want to share what happens if we ask an individual to run on a treadmill, barefoot, and with a shoe. So this right here, the video I'm going to show you, shows you the pressure on the foot when the person was running barefoot and with a shoe. So you can see here the center pressure. So the more the red, the area, it's like a weather map or radar map. So the more it's red, the more there's more pressure. So here's the barefoot, and here the other side is the forefoot. But this is kind of what it looks like. So after that, we ask him, if you were running, are you a habitual forefoot striker or a rear foot striker? And his answer was he's a rear foot striker. So what happens if we take out the shoe, right? If I ask you to walk when it's really, really hot on a pavement, you'll be probably tiptoeing, right? So that's what's happening. If you're running barefoot, what's going to happen is all the pressure, as you can see in here, is on the forefoot. But once you give them the shoe, because he's a habitual rear foot striker, you can see that now there's not much of a red in here, and you see more of the pressure also on the heel. On the bottom is the center of pressure trajectory. So the center of pressure is just where the force is being applied on the foot. So the treadmill that we have, our instrumented treadmill, it gives us kind of the trajectory of the center of pressure. As you can see here, this is also a difference between rear foot striker and forefoot striker. The center of pressure distance is decreased. So now everything, the pressure is on your forefoot. Compared to the heel striker, it starts from the heel, then it goes to your toes, and then back. So it's just forming that. So the computer software is just putting them together. So this is what it looks like if somebody is running with the shoe on. So this is the pattern of the pressure for rear foot striker. Here's the midfoot striker. You can see now that the heel doesn't show up much. And then so this one, somebody was wearing a minimalist shoe like the 5-finger shoe. You can see that all the pressure are on that area. And same as here on the trajectory, it's just getting smaller and smaller. So it's just really centered or concentrated on that forefoot area. So now let's go to what are the factors that contribute. We talked about some of the mechanisms in terms of initial contact, different types of initial contact. Now let's go to the factors. So I'm going to be talking about from proximal to distal. So that's kind of the approach we're going to be looking at. So when we look at here, there are 3 main factors that affect injury on the hip and the knee. So the first one is inadequate use of hip in the sagittal plane. So for those of you who are not familiar with the plane of the body, sagittal plane is when you're looking at it from the side view. Frontal plane is when you're looking at it from the front. Okay? So here, the first one, and I'm going to go in detail on all of them. So the first one is inadequate use of hip in sagittal plane. So what's happening is you're using more of your quads. The more you use your quads, the more you're going to have anterior knee pain or patellofemoral pain. The reason for that is your quads inserts into your patella and then into your tibial tuberosity. The more you're contracting your quads, you're just going to pull that. So your patella is going to be banging into the femoral condyles. So that's kind of the first one. The second one, you have if a person has a poor dynamic hip stability. So what this means is that when you're looking at them from the front, when they're running and they're on the loading response, their knee is collapsing medially. Okay, so when their knee collapses medially. And then the last one is when they have poor pelvis and trunk stability. Now, not just their knee is collapsing, but also their trunk is leaning side to side, and there's excessive leaning side to side, and that could lead to those running injuries related to the hip and the knee. Now let's go specifically to all of those and show you some videos. So this is usually what we do in a clinic to test for quadriceps dominance. It's called a step-down test, very common. So what we ask them to do, they're standing on a step stool, and then they just have the stance leg on the stool itself, and then all they have to do is they have to tap their heel on the ground 5 times, and then see on their side view what their hip and their knee is doing in their trunk. So I'll show you a video of this. So that's kind of very typical on what we do in terms of evaluating the sagittal plane kinematics or motion. So let's pause at the bottom of that and examine what's happening. Okay, one of the things that we looked at is if your knee goes way past your toes. If the knee goes way past your toes, it means that you are using your quads quite a bit. This test kind of mimics the loading response. Remember the different phases of running? We have the initial contact and then the loading response. So this is that mimicking the loading response. So if your knee goes past way your toes, it means that you're using your quads. So again, that could lead to anterior knee pain or patellofemoral pain. So how do we know that? That's based off, if we look at biomechanics, it goes back into review a little bit of physics, torque, right? So torque is the rotational force, and it equals to the force that's being created by the ground, like this yellow part right here, and then the distance of that force vector to the joint center. So if we look at the knee joint center, right here, and then the distance, so that's that torque that's being created, external torque being created on the knee. If we look at the hip, here's the hip joint center, approximately, and that's the distance. So if we compare the distance, because that yellow line or the force is not going to change because that's your body weight, right? So only the line you could manipulate. So you could see here that the distance right here is bigger than on the hip. So we know that if the external torque is higher on that joint, it's going to demand more muscle contraction in order to sustain that torque or that rotational force. Okay? So what do we want to see? This is what we want to see. This is an exaggeration, but this is kind of what we want to see. So if you compare the two, so really the key here is you just have to move your butt back. Okay? So if I am going to do that loading response with my body upright, my knee is going to go forward. If I move my butt back, eventually my knee is going to go back, right? But on running, you can't really lean as much as you can, and usually there is a certain degree that you have to lean forward so that you're using more of your hip muscle than your quads. So here, if we compare, you can see now we decrease that distance from the yellow line on the knee joint center compared to the hip. So now, hip stronger than your quads, we want that. So that's kind of like what we want with our patients to do, and to learn eventually we want to be applied more into running, but here on this test, we kind of want to show them that that's kind of the posture we want you to be. So that's quadriceps dominance. The next one is poor dynamic hip stability. So same thing, now we're just looking at the front view of the person instead of the side view. And guys, I want to show you how the test looks like in the front view. Now we'll pause that again at the bottom. And then we'll do it. So now this is the right stance leg. And now on the other side, it's the left stance leg. And you could definitely tell which one would be abnormal or not normal kinematics. Okay, let's pause there for a second. As you can see here, when the stance leg is the right, the knee is not really collapsing, which is great. However, the pelvis is tilting. Usually the tilt that we're looking for, and we just don't eyeball it. We have specific measurements that we use, but usually, according to studies, it's around 7.5 degrees. So there's a little bit of a tilt happening. But anything above 7.5 degrees, that's a concern. So usually your hip stabilizers are your glute medius. So again, getting that nice glute in there in your back is really great for running. If you look at the left stance, now it's all over the place, right? You see the trunk rotating. You see the knee collapsing inside. So there is a big difference between this. And eventually, if a person's running this way, they're going to experience that patellofemoral pain or knee pain. The last one for the knee and the hip is poor pelvis and trunk stability. So if we're looking at from the back view or the posterior view, you could see that when this person is running, on the left stance, the trunk, it's pretty straight. Usually it's around the threshold that we're looking for here is 10 degrees. If you're going more than 10 degrees to one side, then again, that's going to be indicative of some problems with hip stability. You can see here the pelvic drop is about 2.4, so it's not really concerned. If we go to the other side, now look at that trunk lean. It's going 15.6 degrees, and then the pelvis is dropping around 9 degrees. So what's happening here is, for those of you who are familiar with the test they call Trendelenburg gait. So here what's happening is when your glute med is weak, usually the other side on the stance drops. And then in order for you to compensate, because you're going to lose your balance, you're going to move your body into your stance leg. So eventually this could cause not just knee pain, but also lower back pain over time. Okay, so those are the different things that we kind of check in the clinic to look at different injuries for the hip and the knee. Now let's look at the foot and an ankle. So when we look at the foot and an ankle, majority of the people, when you go to a shoe store, they always look for pronation, right? So foot pronation. So it has been shown that excessive foot pronation could be a factor in terms of foot and ankle injury. But is it really your foot pronating? So pronation is when your arch is collapsing inside. Or your tibia rotating. So that's also a concern if your tibia is the one that's rotating, or your bone on your shank. The next one is the foot contact patterns. We talked about this earlier, right? If it's a rear foot contact or mid-foot contact, it's going to create different injuries to that individual. And then the last one is elevated impact forces, which is the high loading rate. Remember, the steeper the slope of the curve, the more injury. The less steep, the better in terms of loading rate. So this study performed in 2014 looked at the different foot eversion. So eversion is when you are when the medial arch is collapsing in, or pronation. That's another term for pronation. Pronation is more of a multiple planar movement. Eversion is just one plane. So they were looking at the eversion. So they found out that the range needed for eversion should be around 7 degrees. If it's more than 7 degrees, then it could create some injuries to the foot and the ankle. So, however, they found that tibial rotation doesn't really play a role in terms of how much you're pronating. So it's really just the foot that moves for that pronation. In this study, which is pretty cool, what they did was they were looking at how much power is being absorbed in your hip joint, in your knee joint, and the ankle joint when a person's running. So they were looking at rear foot strike, forefoot strike, and a person running barefoot. So they asked them to run about 7.5 miles per hour. That's the speed that they were going. And they were running on about 20 to 25 meter runway, and they were hitting the force plate in between or in the middle. So they found that if a person is rear foot striking, the total power or the total power that's being absorbed in lower extremity is significantly higher than a forefoot strike in barefoot. Okay, so it's significantly higher. However, if you look at how it's distributed in different joints, there's also significant difference. With a rear foot strike, majority of the force being absorbed is on the knee. That's why if you are a rear foot striker, it's mostly on the knee is your problem. However, if it's a forefoot strike, now you can see that the knee is decreased, but where is it now? It's on your ankle. So majority of the forefoot striker would have more of an injury on their Achilles tendon, on your ankle. So that's where the injury is. And then with barefoot, it's significantly decreased too, but it's more on the knee itself too. Okay, so it's pretty unique in terms of looking at this. And one of our graduate students planning to look at using the Hoka shoes and its effect on this power absorption when you are using that really thick soled shoe. So what are the different common running injuries? First one, knee pain. So probably by now you kind of have an idea of what are the different mechanics that causes this. First one is hip internal rotation. So if your hip is internally rotating, then what's going to happen is your knee is going to collapse medially. So that's not, so another term they call that is knee valgus. Okay, so you don't want that knee valgus. What's going to happen if you have knee valgus also is your patella is going to not track properly, or there's a maltracking of your patella because your quadriceps are not in the right angle. Next one is hip adduction. So adduction is when your thigh goes in the middle. So that's kind of like a combination, internal rotation and adduction. That's kind of like that knee valgus position. And then the last one, of course, is a quad dominance. Probably some of you recognizes this person, Preska Jiptu. So in the last Olympics in London, if you look at the form, I was watching this for some reason. I just turned on the TV and they were showing women's marathon. When I saw that, it's like, that form is really bad. Really, really bad. She finished second. She lost by 5 milliseconds. So if I was the athletic trainer working on her, I'm not going to say change your mechanics, right? So again, just there are some individuals that could run with different mechanics because they have adapted to that type. But eventually, I don't know over time what's going to happen to her knee and to her hip and to her ankle. Okay, but she's still running marathons up to now, and she's really, really good at it. Okay, next one is IT band syndrome. So IT band is a fascia that's located on the outside of your thigh, and the muscles that insert to your IT band are your tensor fascia lata and your gluteus maximus. So what's going to happen with the IT band problem is that sometimes there's tightness of either your tensor fascia lata or your gluteus maximus. So probably you guys heard it before that you have to foam roll your IT band. For me, my preference is I want to roll the muscle that attaches to it because that's more extensible than the IT band. So if I know that my IT band is tight, I want to, if I'm using a foam roller, I'm going to do it more on the tensor fascia lata and on my glute max so that I could release the tension on my IT band. In terms of mechanics, a pelvic drop would create that IT band syndrome. Okay, so if your pelvis is tilting side to side, think of it. If you are tilting, if my stance leg is the left and if I'm tilting, this is stretching the IT band. So eventually that would cause that IT band syndrome. Next one, again, the knee valgus keeps on coming back, right? And that's when the knee collapses in. And then foot pronation also plays a role. If you're pronating your foot, there's a big chance that your knee is going to also be affected and it's going to collapse. Last one, and I heard people here talking about plantar fasciitis earlier. This one of the main reasons they're saying for plantar fasciitis is hip extensor weakness. The biggest hip extensor in your body is your glute max. Okay? We always keep coming back to that glutes, huh? So the glute max, the more that you cannot extend your hip because you have weak glute max, when you are pushing off, you're using a lot of your calf muscle. So over time, that could lead to plantar fasciitis because the plantar fascia kind of goes all the way up into the chain, okay, into that proximal chain. So hip extensor weakness, according to studies, are a factor in that. Foot pronation, and then forefoot strike. So think of it, if you have to run and you're always tiptoeing, then that's going to be creating a lot of stress on that plantar fascia. Okay, because you're not allowing time for that heel to touch. And so that's going to be creating that, or it could lead to Achilles tendonitis or plantar fasciitis. So what do we do? Okay, what needs to be done? So there's two different really planes that you want to look at. The first one is you want to look at an individual from the front and see how their trunk is aligned, whether they're leaning to the side too much, whether their hip is tilting side to side, or whether their knee is collapsing medially. So those are the things you want to look at. Next, on the sagittal plane. sagittal pain when you're looking at the side. You don't want the knee to really go way past that toes when they're in the loading response. So this study that was released in 2014, they found out that that number you're looking for trunk angle is 14 degrees. So you need to be leaning 14 degrees forward in order to activate more of your glutes, and you decrease the pressure on your knee, because now you're not using much of your quads. So when you start kind of running, think of just leaning forward. It looks awkward. You know, if you're going to try, it looks awkward leaning forward. But even if you think you're leaning too much, it's not really that much if you look at it, or if you ask somebody to look at your form. So I've been hitting on this, right? That hip stability. One of a good exercise that was released in 2013, they look at different gluteus maximus or glute max exercises and gluteus medius, and they found that the best exercise to isolate the glutes, usually with the athletes that we see, they really have a strong glute. The problem is they can't contract it at the right time. So what we ask them to do is try to be able to isolate those muscles. I know nowadays it's always functional exercise. But it's really hard to go straight into functional exercise if you can't recruit your muscle that needs to be recruited during that motion. So we want to go back into the basics of starting first with, I'm not saying do isolation the entire time. You just want to start your rehab or your exercises with some isolation exercise, like glute strengthening exercises for the first few weeks, probably 2 or 3 weeks, and then go to your functional exercises after that. This is the best exercise according to this study, the clamshell, that increase their glute activity or glute activation. And then you can see here they try different exercises too. They have a single leg bridge, a hip extension with a knee flex. This one is kind of like the lateral side to side with a band. And then here you have extension with the knee extended too. So those are the different exercises that they prescribe if you want to isolate your gluteus maximus. Okay, so what's next on this topic? So our goal in physical education, health and recreation, special and kinesiology program is to try, as I mentioned earlier, to bridge that gap between what we learn in research environment and put it into practice. So we're trying to team up with, starting next fall, we're going to be teaming up with, of course, Western's cross-country team and also some high school cross-country teams in town to be able to start looking at some hip strengthening program. You want to test their some variables, looking at kinematic and strength, give them some hip strengthening program, and try to see if what's going to be the effect of that once their season is over. So hopefully we could decrease that. It's really hard to prevent injury as an athletic trainer. I really don't tell my athletes or my patients, we're going to do this to prevent injury, because you can't really prevent injury, but you could decrease the chance of them getting injured. If I can decrease their chance by 10 or 15%, I did my job. I just can't promise we're going to prevent that, because there's a big chance that they're going to get injured. So my goal is to decrease that chance of getting injured. So I just want to acknowledge some of my collaborators with the research I'm looking at. Dr. Chris Powers from University of Southern California and Dr. Sean Roach from Integrity Physical Therapy in Eugene, Oregon.
I'm wondering, you didn't really talk too much about hamstrings. And I know there's lots of injuries with that area.
So we see much hamstring with, not much with cross-country runners, but with a lot more with sprinters. So what's happening with sprinters, or even with cross-country runners, good example was that looking from the posterior view. So if you have a pelvic tilt, you guys could look at my back, right? And then if I'm dropping here, you could see that my hamstring are going to be stretched. So if you have that pelvic tilt, it could cause some hamstring strain. And if your glutes are weak, your hamstrings, they're a two-joint muscle. they also cross the hip. So their main action is for knee flexion, but they also help with the hip extension. So if I'm strong in my glutes, but I'm not using it for extension, what am I going to be using? My hamstring. So now instead of just using it as a knee flexor, I'm also going to be using it for hip extensor. So now you're overloading that muscle. That answer your question.
So if you're weak in your glutes and tight and strong and, or sort of front dominated, what's your philosophy on, is it just about strengthening the back or being religious about foam rolling and trying to retrain your body so you're not just always quads taking over?
Both, right? So if you have a tight quads, eventually you're going to have a tight, or if your quads are really dominant, eventually it's going to be tight. So you have to stretch it. You could do a knee flexor stretch. You could foam roll it. And at the same time, you want to strengthen that glute when you are stretching your quads. And then you have to check your mechanics. You know, it's an easy check. If you have a mirror, you have a step stool, do it at home, and then you could just see whether when you're landing, if you're moving your butt back, right? So the more that usually technique and strength goes together. Even if you know the technique, but if you don't have the strength to do it, you're still going to go back to your old ways. So you need to work on both, just the technique and the strength. And of course, you have to kind of loosen up that quads eventually because it's just tight.
Yeah, so I think that, you're saying a lot of things that really make sense. But what I wonder about, just as far as the community, what kind of resources do they have to assess what's going on in their bodies? It seems like it's hard, certainly, to do that with yourself. And it's also hard to get to an expert to be able to do that as well.
So this is my second year at Western, so we haven't established that yet. But the first really good person to talk to are your physical therapist. If you know of a physical therapist, they could do all this tasks. They're trained to do it, especially if they're concentrating more on running. Another one would also be athletic trainers. If you know any of athletic trainers in town, eventually we want to open up in terms of getting the community involved in some of the testing that we perform in our lab. So we're going to be moving forward into that, so we could definitely do that in the lab, but we're starting on that. So physical therapists, really good, and our athletic trainers to go to.
So I was curious about, like, if you're having low back, is that with your ITB maybe connected, or running with low back pain? I mean, where does that play? You're talking about the...
Just talk about lower extremity, that's why. So low back pain, another problem. So low back pain, what happens is, if you don't, it goes back to the glutes. If your quads or your hip flexors are tight, what's going to happen when you're running is you can't extend back. So what's going to happen is now you're going to be arching your back to extend. So now you have that, what we call lordosis. Another thing is, if your quads are tight, your quads are connected to your hip. If they are tight, what's going to happen is your pelvis is going to be anteriorly tilting. Now you're going to be walking like a duck, right? What happens to your lower back? It increases the curvature or lordosis. So you see that quite a bit with a lot of athletes, right? When they walk, they're kind of walking like a duck. And sometimes it's because of that quads being tight. And so what's happening is now their pelvis is tilting forward. So doing some quadricep strengthening or stretching or foam rolling would probably help with that, or doing some pelvic tilts. So some posterior pelvic tilts will help, because you want to maintain that lower back to be, because there's always a lordosis or that curvature, but you don't want it to be excessive. But again, with running, it's just, if you can't, so you could lean forward, right? If you can't get full extension, if your quads are tight, you can't fully extend, so you could lean forward, but you could only lean as much before you lose your balance. So how are you going to compensate? You're going to arch your back, right? So eventually that could lead to that low back pain too.
So I'm interested to know what your philosophy is on stretching, because I've kind of heard it go both ways, particularly pre-run stretching, as far as, you don't have too much pain, but you don't want more coming.
So that's really a hot topic right now in strength and conditioning, probably in the last 5 years. Mostly the stretching affects power output. So if you're going to be powerlifting, a lot of the studies are showing don't stretch because you're going to lose that power. But for running, I think it's not really going to be detrimental to your performance if you're going to be stretching. But it's more, they see it with if you are going to be doing some power movements, then they don't want you to stretch. Again, it's kind of not really clear in terms of the benefits of stretching. But if it doesn't hurt you and it makes you feel better, right? So that's kind of my philosophy in that. If it's not going to decrease my performance and I feel better, because there's a lot of psychological thing that's also affecting your performance. If you're always doing stretching and you just read in the news or in the literature that it's not good stretching, but it's not really detrimental to your performance, why stop? But if you're trying to save time, maybe you don't want to stretch and just go straight.
So you know a little bit about my situation. And I'm curious because having been a sprinter, I was a 4-foot runner. I mean, the faster you go, you are on your 4 feet. Becoming a distance runner in my old age, I now see the utility in changing speeds so that my posture, everything about how I'm running changes during my run. Because if I'm just on a 10-mile run, all these things that you're talking about are ingrained. Is there any truth to that actually doing some speed work can alleviate or mitigate some of the things that you've been talking about?
So are you talking about like interval training? Yeah, no, it is. One of the best, kind of right now, one of the best training that you could do is interval training. Majority of the runners, so here's the thing with runners, right? There are more runners that are injured than weightlifters, right? Weightlifters, they do Monday, Thursday, I'm just going to do upper extremity or pull or push. And then on the other days, they do a different part of the body, right? So it's kind of like doing some interval in a way. But with runners, if they're injured and I ask them, okay, decrease your mileage, they're going to say yes. And then when they leave, they go back to their ways, right? So the point is interval training is really great because you're allowing yourself time, and also because you are aware of what your body is doing, you kind of have an idea of how to adjust it. But if you're just running continuously, even if you have that feedback, you go back to your old ways. But if you stop and then just think for a second, and of course fatigue plays an important role in that, right? If you don't have muscular endurance, even at the start, if you're running 5 miles in your perfect form, after that 6, 7, 8, when you're starting to get fatigued, you go back into your old habits. So if you're doing some interval training, you're allowing yourself to recuperate or to be able to go back to that original, you could say a little bit of a muscular strength when you started your workout.
We haven't spoken a lot about ankles yet. With orthotics, what is the recent thinking about that? I got mine about 20 years ago. I haven't replaced them, but I still twist my ankle pretty well now and again. Are those something you should replace? Have they gotten better? Are they worth doing, or should you go without them? What is the thinking on that?
Usually with orthotics, you have to replace it every 2 years. Because it depends on the same with running shoes, right? If you're going to be averaging on the high 40 miles, you have to change your shoes 2 to 3 months, right? But if you're just going to be running 10 miles, then probably you could extend it longer. Same with orthotics. With orthotics, they put a characteristic, they have that characteristic of the plastic that they have to sustain, and then over time, when you apply stress on it over and over again, then it's going to lose that form. So you really have to change it every couple of years or 3 or 4 years. In terms of research, they haven't really seen much of a difference. Especially they put orthotics if you're overpronator, right? Usually that's where they do it with runners. They haven't really seen an effect of orthotics changing that movement of your foot. Usually pronation, it's not a single plane movement. Pronation is a combination movement. So with pronation, usually you are on that plantar flex position and you are in everted position. So I'm not really sure how the orthotics is going to change that position when you are on that push off. Okay, maybe it could, some of the shoes would have that kind of little bit of a height on the middle, so you're not overpronating. So they have that, but I haven't really seen much study looking at or seeing effects of changing the mechanics or the kinematics of the ankle with orthotics. Shin splints. When you talk to a bunch of the healthcare professionals about shin splints, it's a misnomer in terms of it's kind of catch-all term in terms of what's happening on the lower extremity. Shin splints could be caused by forefoot striking too. Okay, the more that you are tiptoeing, the more you're applying. So what happens usually with shin splints, and this is their theory behind shin splints, you have muscles that attaches to your tibia, which is that bone right here. Okay, so there are muscles, and also there's a membrane called the interosseous membrane in between your tibia and your fibula, which is the bones on your shank. And usually what's going to happen is it's pulling away from the bone due to a lot of pressure from forefoot, and they've seen it with forefoot running, that shin splints. That answer your question?
Given the geography here, I think a lot of us are trail runners, and so we spend a lot of time going up steep hills and down steep hills. Have you got any specific advice on how to run in those conditions? I think a lot of your studies have been done on the flats rather than up and down.
If I had a choice in terms of what's going to be better for the hip, knee, and ankle, uphill would be great. When you're running uphill, the tendency of your body is what? To lean forward. When you lean forward, studies have shown when you're walking, you're not really engaging your glutes. So they've seen that the more you lean forward, the more you're engaging your glutes. So when you're running uphill, you're sitting down, right? So your butt is more back. Downhill is really bad for your knees, right? Because there's a lot of that, really don't want to use that term, but decrease in acceleration or deceleration. So that deceleration is going to come from either your hamstrings or your quads. And it's really hard to change that mechanics going downhill. It's hard to lean forward when you're going downhill because you might, fall face flat in your face. But as much as possible, try to, even if you want to lean back, because that's kind of the tendency when you're running downhill is to lean back. Try to be upright as much as you can so you're engaging that glute. So when you land, you're not just using your quads and your hamstrings for deceleration, but you're also engaging your hip complex or your glute complex with that attenuation. That answer.
I will engage my glutes and use my rear foot strike to get here. So please join me in thanking Dr. Jun San Juan.